What I discuss with patients is the number one key actually is not so much a technical or medical issue, but it's actually the patient themselves. It's a highly motivated patient. So it's really the patient who has lost weight from their initial operation. It's my belief that if we catch them early, so early on their path of weight regain, they'll actually have the best result. So once they notice that their weight is increasing or they have return of their diabetes and so forth, I think it's best to catch them early. But really the most important thing is the motivated patient. So the patient who on their own has realized that they're gaining weight, reinvigorating their efforts with diet and exercise, and then they come to see me. And most patients will describe to me what I describe sort of the hamburger test. So when they first had their bypass operation, they could have maybe a small sliver of a hamburger or a couple of bites, and that's it. And then over time they can eat more and more. And oftentimes when I see patients in consultation, they'll describe that they can actually eat basically half or even a whole hamburger. And usually once they've reached that point, we know that the anatomy has sort of dilated. So we try to capture patients as soon as possible on that sort of weight gain curve, and I find those patients have the best result. And remember, with this procedure, we're not changing the bypass. We're not sure if we're changing the gut hormones, although I believe that's the case, and we're studying that here. Really, we're just affecting the pouch and the restriction that we're achieving. So that's just one aspect of the operation. So really, I describe this to patients as a tool to help them sort of get back on the path of weight loss. Insofar as studies are concerned and following patients, we really don't have data beyond 1 or 2 years. And so we know that in the vast majority of patients, at minimum, we can arrest their weight gain, meaning that usually by the time they see us, they're sort of marching up in their weight and heading back to their preoperative weight. And when we do this procedure, we can halt it at least. In terms of actual weight loss, most patients are going to lose on the order of up to probably 50 pounds or 25 kilograms at most. It varies from patient to patient, and certainly the most motivated patients I've had have lost actually significantly more weight. But on average, at minimum, we're going to arrest their weight gain, and on average, they're going to lose anywhere from 10 to 25 kilograms. Certainly, the primary operation has failed in the sense of, the pouch is stretched. And so obviously we can have that same experience with our own procedure here with the endoscopic procedure. If that were to occur, there are options. So our practice here at UCLA is that we'll start with this TOR procedure or this endoscopic procedure. If the patient has lost weight, but then they feel suddenly that they've lost that satiety that they gained from the procedure, we can reevaluate their anatomy and we can actually repeat the endoscopic procedure, certainly given its minimal risk profile and minimal impact on their quality of life in terms of the perioperative period. So we'll oftentimes repeat the procedure. The other option is that we'll actually step up in our treatment. So if they've essentially not responded to the TOR or endoscopic procedure, we'll step up to revising their bypass surgically, so another operation. In the published literature, there are improvements in lipid profiles, high blood pressure. We haven't seen actually statistically significant reductions in diabetes, although anecdotally I do see that. And obviously it depends on the degree of weight loss patients are able to achieve. But remember, when we lose as little as 5 kilograms, there are significant improvements in insulin resistance. And so that's really what we're trying to get towards. I've also seen patients in terms of mood. So, obesity in and of itself is associated with psychiatric disease and depression through primary inflammatory means and macrophages in the brain and so forth. And I've actually seen patients who have been able to wean off antidepressants and associated with doing the procedure, any revisional procedure, whether it be surgical or the TOR procedure.